Hello, welcome everyone. Let's get started. It's a few minutes past 5 and it's an absolute pleasure to have you all with us today on a Saturday. I'm sure you could be doing tons of other things, but you've joined us on one of our OSCE webinars, so I'm absolutely delighted. My name is Shoaib. I'm one of the co-founders of Bite Medicine, and I've had great fun doing this OSCE week with Aaron, who's a good friend of mine and has aced his OSCEs multiple times in the past. So he's the guy to go to for OSCE prep. We've done cardio, resp, neuro, and abdo, and today we're just going to cover some high yield cases that are almost or very likely to come up at some point in your medical career. There's quite a lot to get through, so I want to crack on, but just before I do that, for our certificate scheme, if you have attended a live webinar and fill out the feedback form at the end, you are eligible for a certificate from Medigate. If you haven't received an email about that, give it another week or so and they should email you and they update it on the portfolio on their website. We'll do a Q&A at the end, so if you have any questions, please keep on to them, or we'll try and answer them in the chat. Azim and a few other doctors are around to answer your questions. But without further ado, should we get started, Aaron?
Yeah, awesome. Thanks, Shoaib. Okay, so hi guys. So last session of the week on OSCEs. So hopefully you guys have found this so far useful, and if you're new, then welcome. So yeah, me and Shoaib went to uni together, graduated about almost coming up to 3 years ago now, and we kind of studied for our OSCEs together from year 4 to year 6. And this is basically kind of some of our notes and kind of various collections of that modified over year and year put together. So what we're going to cover today, we're basically going to quickly go over kind of the approach that we use very, very quickly, and then we're going to go over 4 cases. We're going to do a bit different to what we've done before. All our previous webinars are kind of available if you've missed them, kind of on record, which we'll talk about at the end. But today we're going to imagine that you're in your final year or your 4th year or 1st year OSCEs, and we're going to cover station by station. So rather than doing 4 cardio cases in a row, you're going to try and see one case will take about 30 seconds, and then we'll go into another station, and then we'll go into another station. So it's all going to be different. So it really gets you thinking, and it'll be about 70 minutes. And there you can see the Bite Medicine website to get the slides, which should be already up, and recordings after the session. So you've seen this before, most of you, but I'll quickly run over it in less than a minute. So the retrospective approach, the last time you'll hear me say this, I promise. So how we should recommend preparing for OSCEs, especially considering that a lot of you will not be going to placement for a while. And if you will be, you won't have the same luxury as normal with social distancing and things like that. So if you're preparing for your cardiovascular or your respiratory or abdominal or thyroid, we recommend actually starting with an OSCE cases list. So think between you and your friends, what are the most common causes, what are the most common cases that are likely to come up in your kind of station? For example, we've gone through this before for your cardiovascular. There's not many, your aortic stenosis, mitral regurg, valve replacement, and your cabbage. And once you've got that, then each of those, split them amongst with your friends and prepare your viva for those cases. It doesn't take long, but really go in detail. So think, what are the positive findings on all of those cases? How would I put those findings together into a neat presentation where we talk about positive findings and negative findings? We'll go over that quickly. What are the risk factors of that disease? Kind of questions that you think they could throw at you. What are the signs of complications? Are the differentials? And how would you investigate and how would you manage this patient? So you're starting here with the viva, and retrospectively you're moving towards a routine. So you've done this, and then we recommend preparing your examination routine, because here at this stage, you can go to your Geeky Medics where you can find, or wherever you want to go to find your examination steps, but it's the signs you're looking for. So now you know when you're looking at the hands, you're not just reeling off 8 things to say, you know deliberately what am I looking for and why, and how this ties into my kind of differentials at the end of it, because it's all well and good performing an examination routine, but at the end of the day, we want to be good doctors. We want to be able to diagnose and pick up the relevance of signs, and the relevance of absence of signs is just as important. So I saw a tweet today, if you're not following us on Twitter, go follow us now. But basically, someone's talking about finger prick marks, and finger prick marks are something that, unless you look for them, you are so unlikely to see them. If you see them, then you can be almost certain that this patient is diabetic and has been a diabetic for ages, because they've continuously kind of pricked their fingers to leave very small marks. If they're not there, then that gives you the idea that this patient is probably not diabetic. So already you've got this idea, is this a vascular patient? Are there vascular risk factors I need to think about? That's just kind of one tip. So really kind of making your examination routine kind of differential based is really, really helpful. So that's enough of that. Just to summarize what I mentioned before, how we present findings. So take away this, if there's anything, start with your introductory sentence. I performed a thyroid examination or neuro examination on this patient. And we want to try and commit to something from the start. If we have no idea after exam, fine. We have no idea, we can't say that. But if we have an idea, using the retrospective approach, we should have an idea of where does this most likely fall into. For example, mitral regurg. And the reason why we say it from the start is because as an examiner, and I've sat in on some OSCEs last year when I was, 2 years ago when I was in F1, if you suddenly hear the diagnosis from the first second that student starts speaking, it's thinking, okay, so I'm interested now, I want to hear what they say. How are they going to prove to me from all their positive findings that this is the correct diagnosis? And then you kind of list off the findings you found, and then we talk about relevant negatives. And it's really, I would say it's impossible to come up with relevant negatives on the spot. But if you revise with an OSCE-based approach, a case-based approach, you know that these are the risk factors I'm talking about. For example, my relevant negative findings are, I couldn't see any finger prick marks to suggest diabetes. That's a vascular risk factor relevant for cardiovascular exams. Signs of decompensation, for example, pulmonary or peripheral edema in cardiovascular, and then the associated features, which are really case relevant. And then you kind of summarize at the end. So just a quick whistle-stop tour. Most of you have probably heard that from me this week and kind of sick of it. So hopefully you won't ever hear that again, but hopefully you did find it useful. Okay, so we're going straight into the first case. And like I said, we're going to do different examinations for each case. So we're doing an upper limb neurological examination in this case. And here are our findings. So have a look. We can see a walking stick. We can just looking at the patient's face. I'm not going to give any clues away, looking at the patient's tummy. And these are actual findings when we do our examination. So tone is normal, reflex are normal, coordination is normal, sensation is normal. And the only real positive finding from our neuro exam is 4 out of 5 movements in the shoulder. So really, really subtle. So actually most students will only pick up on that. But by using this case-based approach, we're showing you actually pick up on everything else globally there. So I'm going to switch to the poll now. And we're going to do an MCQ. So this is a case of proximal myopathy, okay? Try not to put any answers in the chat, please. So I'm going to launch this poll. So which of the following is not a cause of proximal myopathy? Which of the following is not a cause of proximal myopathy? Have a think about that. I'll give you about 30 seconds. We've got Cushing syndrome, myotonic dystrophy, Becker's muscular dystrophy, dermatomyositis, and lipid metabolism disorder. So it's not the easiest one. So put down an answer. Also, well done if you're here on Saturday evening. So about 10 seconds left. Put down answer. 3, 2, 1. Which of the following is not a cause of proximal myopathy? So kind of an even split, with probably most of you going for lipid metabolism disorder and kind of a bit of a split between the others. Okay, so not the easiest question to start with. Today is a high yield OSCE case. It's going to be kind of difficult questions, difficult cases. So the correct answer is myotonic dystrophy. So which of the following is not a cause of proximal myopathy? We're going to go through these individually. So this case you'll see is a case of Cushing syndrome. And that's actually a common cause of proximal myopathy. Cushing syndrome, I remember as C and C, is due to elevated cortisol levels. And there's lots of possible causes for that. But Cushing syndrome is elevated cortisol levels. And that does cause proximal myopathy. And we'll see why, because of that cortisol being raised. Myotonic dystrophy. So this is a condition that actually causes more distal weakness rather than proximal weakness. So what do I mean by proximal? Proximal is kind of your shoulder muscles, your kind of thigh muscles. distal is your fingers, your small muscle of the hand, and your small muscle of the feet. So myotonic dystrophy causes more of a distal weakness than a proximal. And other features that are linked to myotonic dystrophy are frontal balding and kind of a long face. And you know that from the wasting of the temporalis muscle and the masseter. Sometimes you ask them to clench their teeth and you can feel wasting there. So that's the correct answer here, because it does not cause a proximal myopathy. Becker's muscular dystrophy is linked to something called Duchenne's muscular dystrophy. They're both kind of genetic causes of a proximal myopathy, and they're X-linked. So they do cause proximal myopathy, and the kind of MCQ finding associated with both of them is calf pseudohypertrophy. So these patients have very large calves, but rather than being full of muscle, they're actually full of kind of fat and things like that. So Becker's is less severe and Duchenne's is more severe. Then dermatomyositis, another cause of proximal myopathy. Will give you a good kind of way to remember all of these causes of proximal myopathy. This is an inflammatory condition where you get the proximal myopathy along with a rash called a heliotrope rash, which is commonly affects the eyes, where you get kind of a purple rash kind of under the eyes, and Gottron's papules, which is kind of these purple kind of spots at the knuckle area. And then lipid metabolism disorder. This is a really rare genetic disease, autosomal recessive. Examples are Gaucher disease, Niemann-Pick disease, Tay-Sachs disease. That causes kind of, there's the problem in this disease is you've got a mutation that means that you can't break down lipids, therefore you get these raised lipid levels, and also you get a proximal myopathy with that. So quite complex, but here the kind of clue in these questions which say not a cause is usually one of them causes kind of the opposite. So here we've actually got distal more than proximal weakness. Okay, so let's go back and quickly have a look at this case. I've told you it's a proximal myopathy, but really it's very, very subtle, very, very subtle. So you really need to go and have a look at that. But the giveaway is actually some of these features that you can see here, which if you're not looking for them, when you go into a neuro exam, you're probably thinking, okay, tone, power, reflexes, coordination, sensation, and that's it. But if you have a look at these subtle findings, then you can think, oh, okay, so I'm expecting kind of a proximal myopathy because I know these findings are consistent with Cushing syndrome. Okay, so how would you present these findings? So I performed a peripheral neurological examination on this patient who has signs suggestive of proximal myopathy. We start with that introductory sentence and we try and commit. I always like to say suggestive of, because I think you can never say for sure. No one can say for sure from just an examination. We always get taught history examination what a diagnosis is. So you're just showing what you think. And there's nothing wrong with committing and being wrong, because you're just saying it's signs suggestive of. If you're wrong, okay, fine. Then you kind of talk through it with your examiner. Then you list out your positive findings. So my main positive findings are on general inspection, very important. Never leave the general inspection out. I can see the walking aid, a large body habitus with predominantly central adiposity. So that just means the fat is kind of predominantly in the kind of abdomen area. And you can see that from this picture over here. And then evidence of an increased transverse diameter of the face. So this is commonly called a moon facies in textbooks and things, but I think with a patient there, it's really, really bad to say that. So this is kind of the okay way of saying evidence of an increased transverse diameter of the face, and your examiner will know exactly what you're talking about there. Power was moderately reduced in the proximal upper limb movements. So a lot of people will only mention that. Okay, so you're already picking up on extra findings. You go into negative findings. So in a neuro station, it's quite easy. You can just say negative findings are kind of the normal aspects of your examination because it's a very structured exam. So my relevant negative findings in this case are there was normal tone, normal reflexes, normal coordination, and then sensation was normal in all modalities tested, whether you use proprioception, light touch, pain, temperature. To summarize, this points towards a proximal myopathy. So there you go, you've got a really, really good presentation. But here we always try and go one step further and just add in, using all that holistic approach, all the kind of case-based approach, picking up on extra findings and the absence of findings as well. There was presence of Cushingoid features, such as a large body habitus with predominantly central adiposity. There was abdominal striae. So those were these red kind of, they look like stretch marks, but they're kind of basically where there's been breakdown of the skin and kind of tissue there. And we'll talk about why that is in Cushing's. And increased transverse diameter of the face. So that's the moon facies. And the most likely cause is proximal myopathy secondary to Cushing syndrome. So there you go, you've got really, really good presentation. Just want to say something. If you didn't see any of these features, that's absolutely fine. You can still go further at this point. You could say this points towards a proximal myopathy. I could not see any signs of Cushingoid features, such as a large body habitus or abdominal striae, which makes Cushing syndrome less likely. So you're already saying that, I know it's proximal myopathy, but I couldn't really tell if it's Cushing's. I couldn't really tell the cause, but yeah, I don't think it's Cushing's. You could be wrong, but it's just showing that you're very global when you're doing a very global assessment. And there's no way that any of us can just pick that up on the spot. That's from doing the retrospective approach. Okay, so you've done really well. Then they go on to say, this patient does have a proximal myopathy. Well done, well done. What are the possible causes? And we've gone on about it all the time to try and classify your answers. So this is a really neat way of classifying all of these causes over here of proximal myopathy. And it's a good way to kind of remember them for MCQs as well. So we can classify proximal myopathies into dystrophies. And what are dystrophies? They're kind of hereditary degeneration of the muscle. Both of these are X-linked diseases. And we've talked about how Duchenne's and Becker's both present similarly. They have that calf pseudohypertrophy, so often these patients end up in wheelchairs. Becker's is less severe, so Duchenne's usually are patients that don't always survive to kind of till full life expectancy because kind of they're kind of in wheelchairs and things like that quite early on. So Duchenne's is more severe. Inflammatory causes, so this is an autoimmune process, and they're both the myositis. So myositis is kind of muscle there, so inflammation of the muscle, that's why it's an inflammatory cause. And dermatomyositis and polymyositis are just two different forms. We talked about dermatomyositis features also being this heliotrope rash around the eyes and the Gottram papules on the knuckles. Other causes include metabolic causes such as glycogen storage or lipid metabolism disorders, which we mentioned. And finally, proximal myopathy secondary to other causes, for example, systemic disease or drug-induced causes such as medication. So your Cushing syndrome we've talked about, which is in this case, and that's because you've got raised cortisol levels, C and C. But there are other causes as well that can cause a proximal myopathy, such as thyroid, hyperthyroid, acromegaly, and other drug-induced causes such as statins. So lots of causes there. You don't need to mention all of them. I would say it's more important to actually classify than mention all of these. So I'd say there are 4 possible kind of ways to classify this: dystrophy, such as Duchenne's, inflammatory causes such as dermatomyositis, metabolic causes such as lipid metabolism disorders such as Gaucher's disease, and also proximal myopathy secondary to other causes such as a Cushing syndrome, where you've got secondary to elevated cortisol levels. You've given like loads of answers there, you've given loads of it kind of classifying, and you mentioned the most kind of high yield cases. Brilliant. Okay, so you've classified, you've said the causes. Then they say, what would you like to do next? It's a very broad question, very vague question, but you can really answer this anyway. You could say, I'd like to do examinations, I'd like to do investigations. So we've basically gone with the road of, okay, I know how to classify my investigations already. I know we do bedside bloods, imaging, and special tests. But I'm going to go one step further. I'm going to add in further history, which is always essential, and further examinations. So if this question said, how would you investigate this patient? You literally just start here. So what would you like to do next? I'd like to take a full history, especially focusing on a drug history, because we know steroids is one of those causes here. You could put steroids here. Cushing syndrome is basically from steroids. Cortisol is just kind of another form of hydrocortisone, so it's a steroid basically. I'd like to do a lower limb neurological examination because we've done upper limb. We want to confirm our findings if they're kind of consistent in our lower limbs. I'd also like to assess visual fields for pituitary tumor. We've done our examinations and our history. I'm going to bedside. So bedside, I like to look for blood pressure because I know hypertension is related to kind of Cushing syndrome. I like to check a CBG, capillary blood glucose finger prick marks, because diabetes is also associated with Cushing syndrome. I like to do blood tests of Cushing syndrome. Kind of diagnostic tests for Cushing syndrome are, number 1, to measure the cortisol levels. Remember, cortisol is increased in Cushing, C and C. I'd also like to do a dexamethasone suppression test. We've talked about this in detail in one of the other biomedicine endocrine webinars. So we'll put a link to that at the end, or we can go through it in the Q&A. But basically, that is your diagnostic test. You've got low dose and high dose. We can talk about this at the end if you want to confirm. That is your diagnostic test to confirm Cushing syndrome. So you can't just do an elevated cortisol. A diagnostic test is a dexamethasone suppression test to confirm that this patient has Cushing syndrome. You can also do a high dose dexamethasone suppression test, which allows you to identify the exact cause of the Cushing syndrome, because you can subclassify it, which we'll see in a little bit. I like to do some more blood tests to look for other causes of proximal myopathy. You can't be sure it's Cushing's from your examination. For example, TFTs, antibody tests for the inflammatory causes we mentioned, and also raised creatine kinase, which is in those dystrophies such as Becker's and Duchenne's. Imaging now for Cushing syndrome, I want to do an MRI pituitary because I'm worried about pituitary tumor causing Cushing's disease. So Cushing's disease is basically when the pituitary tumor releases ACTH, which goes on to cause cortisol release from our adrenal glands. So it's just kind of one step further, one step behind, causing that elevated cortisol levels. We've got a good diagram of this later on, so you could check that. I'd also like to do a CT thorax because I know small cell lung cancer is associated with ectopic ACTH production. Once again, the ACTH goes on to cause raised cortisol levels from the adrenal glands. So those are both for Cushing's syndrome. Other causes of myopathy, I know Duchenne's and Becker's are linked to kind of dilated cardiomyopathy, so I like to do an echocardiogram. And then special tests. So these aren't really needed for Cushing syndrome, but once again, to look for other causes. So an EMG, basically testing the kind of muscle kind of function, various amplitudes, because we've got proximal myopathy. Genetic causes, so dystrophin gene on chromosome 21 for both Becker's and Duchenne's. And then a potential biopsy, kind of if we're kind of worried from the muscle, is this potentially a tumor or something like that? So I put loads and loads and loads of investigations there. And it's probably quite scary. It's kind of scaring me as well, just looking at this. But you do not need to mention all of this. We put loads in there because even if you remember 1/3 of those, you're still going to be able to classify and mention 1 or 2 things of each. Examiners don't have like all of these on their exam, all of this on their mark scheme or anything. It's all about, can this patient give me a sensible, kind of thorough, classified answer? But hopefully you're starting to understand why these are all relevant investigations. Okay, so they then say, okay, great, you've worked out that this is Cushing syndrome. Now I want to see, do you know what are other associated signs and symptoms seen in Cushing syndrome? So I'm going to do a little bit of theory here, because I think this will help you understand everything. Cushing syndrome, we know, is related to elevated cortisol levels. Elevated cortisol levels, CNC, you'll never forget that. And this is a kind of axis of kind of for cortisol. We've got hypothalamus, which releases corticotrophin releasing hormone, which causes our anterior pituitary to release our ACTH. ACTH acts on our adrenal cortex, which is just kind of the outer layer of our adrenal glands, to release cortisol. And then we've got these negative feedback loops. So if this is raised, we have our Cushing syndrome. But there's lots and lots of possible causes for our cortisol to be raised, which we'll come on to. But what does raised cortisol actually do? Why do we get all of these symptoms, such as our moon phases, which we call our increased transverse diameter? Why do we get abdominal striae? Why do we get proximal myopathy? The best way to kind of remember this is cortisol is your body's stress hormone. So when you're stressed, cortisol is high. When you're not stressed, cortisol is normal or low. So that makes sense because cortisol follows a circadian rhythm. We want it to be highest in the morning when we wake up and we're ready to get on with the day. And when we kind of watch our Netflix and chill out in the evening, cortisol drops. And that's just our normal kind of way of cortisol levels kind of change. So when we're kind of in this stress mode, when we want to kind of get going, your body needs energy. So how does it do that? It wants to get as much glucose as possible because glucose is an optimal source of energy. So it tries to promote these processes. So we have gluconeogenesis. Genesis means make, neo means new, and gluco means glucose. So we're trying to increase the formation of new glucose. And how do we do that? By breaking down lysis, protein, and by breaking down fat. So all of this is to try and give us more energy kind of to get through our day. So when cortisol levels are high, we've got loads of glucose, which causes things like diabetes and obesity. We've got breakdown of protein, so we've got proximal myopathy. We've got kind of that abdominal striae because all of our muscles and our kind of skin are kind of break down. And we've got loss of our kind of fats, so therefore we get kind of different kind of symptoms from that as well. So that's why cortisol levels and Cushing's gives us these kind of symptoms that we've talked about. Once again, we want to classify this. So you could say, what are the symptoms or signs seen in Cushing's? Cushing syndrome is due to elevated cortisol levels. The main symptoms of Cushing syndrome can be classified into catabolic and metabolic effects. So our catabolic effects are from these breakdowns. So breaking down our muscle, breaking down the protein in our body, breaking down the fats. Catabolic means breakdown. So our proximal myopathy from breaking down our muscle, the abdominal striae from breaking down the kind of skin tissue there, our bruising because we're more likely to bleed because we've got kind of less kind of protection there, our osteoporosis from our bones. Metabolic effects are from our increased glucose levels. Remember our gluconeogenesis. So we have all this extra glucose, what we're going to do with it. When they're diabetic, and these patients are going to become obese. So that's a really nice kind of way to summarize causes and symptoms, of Cushing syndrome. And hopefully that explains why we get these symptoms. I think it's always so hard to remember in MCQ, is this a symptom of Cushing syndrome? Well, think of it, the catabolic thing, because you're breaking down to make new glucose. So hopefully that kind of makes things, put things together. Okay, so we've talked a lot about kind of Cushing syndrome, the causes, the symptoms. I'm going to talk about last thing, which is causes of Cushing syndrome. So we've said Cushing syndrome is because our cortisol is elevated. Okay, our cortisol levels are elevated. I think you can think of it as 4 reasons why our cortisol is elevated. Okay, and these are our kind of 4 reasons. I'll try and explain it first. So don't look at this yet. Exogenous steroids. So remember what I said, cortisol is normally made by our adrenal cortex. An alternative of cortisol is hydrocortisone. So that's our external steroids, for example, our prednisolone. They're all forms of steroids. Cortisol is basically our body's form of a steroid. So one reason why you get the Cushing syndrome signs is because rather than the cortisol being made by our adrenal cortex being high, we're pumping the body full of oral steroids or IV steroids, such as prednisolone or hydrocortisone. If you've got all these extra steroids over here, then you're going to have elevated levels of cortisol or steroid to cause all these side effects, which is gluconeogenesis, proteolysis, lipolysis, etc. So that's one cause. A second cause is we've got kind of an adenoma in our adrenal cortex. And if 10 cells make X amount of cortisol, and rather than 10 cells, we've got 25 cells, we're going to make more cortisol. So therefore, you're going to have these elevated cortisol effects. So both those are 2 fairly common, well, not common, fairly easy reasons to understand why. The reason I put them under ACTH independent is because those reasons, the external steroids plus the kind of adrenal adenoma, are completely independent of ACTH. Remember, ACTH regulates the production of cortisol, but these are all kind of right at the distal end of this pathway, right at the end of this pathway. So they're ACTH independent. So for example, these patients will have high cortisol levels, but they'll have low or normal ACTH levels because of that feedback loop. Now let's focus on this. ACTH dependent, and these patients also have high cortisol levels, but this is because we've got originally high ACTH levels. So it's a high ACTH that's driving the raised cortisol levels. Why? Similar to adrenal adenoma, you've got a pituitary adenoma that's pumping out loads of ACTH, which goes on to make loads of cortisol. So that's fairly kind of self-explanatory. If you've got an adenoma here, you have high ACTH, plus you have high cortisol. And this is just called Cushing's disease. I'm not sure why this one's called disease. All of these together could be a syndrome. The way I think of it is syndrome is usually quite broad. Disease is one specific thing. So your pituitary adenoma is just called Cushing's disease. So try not to get those mixed up in an OSCE, but the examiners would jump onto that. So always say Cushing syndrome because you're safer, you're covering your backs. Finally, the other one, ectopic ACTH production. So you've got the lungs over here with a small cell carcinoma. Paraneoplastically, that can release various things like ADH, SIADH that causes. One of the things it can release is ACTH. So if you've got lots of ACTH coming from your lungs, it causes cortisol release from adrenal cortex. That's why those two are ACTH dependent and these two are ACTH independent. Overall, they all have elevated cortisol levels. Okay, so hopefully that makes sense. Once again, we're classifying. Brilliant. So that's the end of the first case. it's quite a broad case. Our Cushing syndrome can come up in our neuro exam, as it has done in this case. It could also come in our abdominal exam, where you see the kind of truncal obesity with that central fat distribution. You can see the abdominal striae, so be aware of that. Just want to check before the second case. Everyone happy with the pace? Too slow, too fast, or are you guys okay with it? And just be as honest as possible. Okay, most people are saying it's okay. A little bit fast from some. Okay. Okay, most people are saying it's okay. Brilliant. Okay, so let's go on to the next case. Okay, so cranial nerve, everyone's least favorite kind of examination, I'd say. And I'm an ophthalmologist, so I find it okay. But I didn't like it at the start. So cranial nerve exam. You go into your station and this is what you see. A female, about 30, and you see this. Eyelids a little bit low. And you do all our cranial nerve examinations and they're normal eye movements, normal sensation, facial movements are normal, I should say. Normal hearing and balance, normal. So you're like, oh, okay, so what's going on here? Okay, so what do we call this? We call this a ptosis. Let's have a look at our first MCQ. Which of the following is not a cause? Oh, sorry. Let's just go to this. Which of the following is not a cause of ptosis? Which of the following is not a cause of ptosis? So have a look there. I've got myasthenia gravis, oculomotor, which is a third nerve palsy, Horner syndrome, giant cell arteritis, and D, myotonic dystrophy. Which of the following is not a cause of a ptosis? We've got ptosis here. Which of the following is not a cause? 10 more seconds, guys. 5 seconds. And stop there. Okay, so most of you have gone for giant cell arteritis. A few of you have gone for myotonic dystrophy. We've got Horner syndrome, third nerve palsy, and myasthenia. So well done. The correct answer here is giant cell arteritis. Let's go through it. Myasthenia gravis does cause fatigable ptosis. So myasthenia gravis is all about fatigability. So basically your muscles kind of get more tired as you do repetitive movements. So over towards the end of the day, you normally get ptosis. Third nerve palsy causes 3 classic signs. Ptosis with impaired kind of eye movements. And if it's a surgical third nerve palsy, you get a dilated pupil. If not, then you may not have that. Horner syndrome causes ptosis, mycosis, and hydrosis. Giant cell arteritis does not cause a ptosis. Instead, it causes this temporal headache, scalp pain, sudden visual loss, jaw claudication, emergency in ophthalmology. And our myotonic dystrophy, which we mentioned before, if you can remember, causes that distal weakness. It can also cause a ptosis. So the eyelid muscles can also get affected in a myotonic dystrophy. And it also causes that facial muscle weakness with their temporalis and masseter being kind of wasted. So you get that kind of long face. So the correct answer here, well done, is giant cell arteritis. Okay, so this is a really, really difficult diagnosis to come to unless you've seen it before. So hopefully a few of you get this case in your exam and you absolutely smash it, because the key finding here is normal examination, ptosis, plus that. That is really, really important, okay? Female and middle-aged. So this is myasthenia gravis. Excuse me. I performed a cranial nerve examination on this patient who has signs of a right-sided ptosis. My main positive findings are, on general inspection, I noticed a right-sided partial ptosis. Partial because it's just not completely covered the eye. That's all you can say. Then you talk about negative findings, and this is how we really get into relevant negative findings. So you know there's an eye issue. At the moment we think it's an eyelid issue, but these are relevant because they help us remove those other differentials we talked about of a ptosis, such as a third nerve palsy or a Horner syndrome. We've got normal optic nerve function. You can say, for example, there's normal visual acuity, normal color vision, pupils were equal and reactive to light. That immediately rules out both your Horner syndrome, because we know Horner's causes a miosis. There are normal eye movements. That wouldn't be the case if you've got a third nerve palsy. And there was normal testing of all the other cranial nerves. So rather than saying my relevant findings are there was normal testing of all cranial nerves, you're being a bit relevant here. You're showing why this is essential and why this is more important. So you summarize, this points towards a partial right-sided ptosis. The cause is unclear because you cannot just say for sure this is myasthenia. But what you can say is the absence of any signs of impaired eye movements, which would point towards a third nerve palsy, the absence of any signs of a constricted pupil, which would point towards a Horner syndrome, plus the unilateral nature of symptoms, this is only affecting one eye, we'll see why that's very important, makes one possible cause myasthenia. Do you see how I've not said makes the most likely cause myasthenia? It's such a difficult diagnosis to make just by doing this. There's blood tests involved, lots of things, but you're showing the examiner, I don't think it's a third nerve, I don't think it's Horner's, but I think with the age of the patient, with the gender, with the fact that it's unilateral, myasthenia could be an answer here. You might be wrong, but the examiner is no way going to think anything bad of you by you suggesting myasthenia as one possible cause. Well done. So now we go, what are the possible causes of ptosis? So all you found is ptosis. Do a little bit of theory. My favorite thing, ophthalmology. So elevation of the eyelids controlled by two muscles. I'll just keep it very relevant. You've got your levator muscle here, your levator palpebral superioris, which is controlled by your third nerve. And you've also got another muscle which plays a little bit of control, which is your superior tarsal muscle, which is this muscle here coming onto the tarsal plate. There you go. It's not labeled there. That's also called Muller's muscle, and that's by your sympathetic system. So that gets knocked out with your Horner syndrome. That gets knocked out with your third nerve palsy. So that's why both of those cause ptosis. But how does that help us with the possible causes? What do we love to do? We love to classify. Once again, we've managed to classify. So possible causes of ptosis. Easy, start easy things. There are 4 possible causes of ptosis, which I can classify as mechanical causes. For example, a large upper lid lesion, such as a tumor or edema of the upper lid, would cause gravity causing ptosis. If you had a tumor here, some people have a chalazion, you've all probably seen chalazion. That causes a little bit of ptosis because of just the weight of that extra mass causing ptosis. Myogenic causes, myo means muscle. So the muscle is not working, myopathic, such as myotonic dystrophy. We talked about this, how that causes a distal weakness. It also sometimes affects the eyelid muscles. So myogenic can be subclassified into myopathic diseases, such as myotonic dystrophy, or neuromyopathic causes. So that's when the nerve to the muscles affect, or not the nerve, but neurological causes such as myasthenia gravis. And we'll see why that's a neuromuscular junction problem. Myasthenia gravis, we've got antibodies to our basically the channels there. So neuromyopathic causes such as myasthenia gravis. Neurological causes which does affect the nerve, a third nerve palsy, which has lots of causes such as MS or microvascular causes, and a Horner syndrome, which is damage to our sympathetic pathway. And then aponeurotic. So if we go back to our diagram, aponeurosis, we can't have got it here, but basically, if this is our upper lid, which is this yellow bit here, we've got something here called aponeurosis, which is basically the big, thick part of our upper lid. And when you get elderly, that basically starts to kind of get disinserted from our LPS, our levator palpebral superioris. So what would that present with an elderly patient? And that's usually bilateral, so symmetrical ptosis. So normally you don't notice it because both eyelids are at the same level. So that's a really good summary, I think, of ptosis. You're basically saying from your examination, I don't think it's this because it's not bilateral and the patient's quite young. I don't think it's this because there's none of the associated eye movement problems. I don't think it's this because it's no meiosis. This I can't see. And myotonic dystrophy, we've talked about how they'd also get kind of frontal balding and kind of wasting of the temporalis, wasting of the masseter, which we'd feel over here. So this leaves really myasthenia as the only possible cause of a single ptosis with no other findings. That's unilateral. So there's no way I'm expecting anyone to get that by themselves, but that's why we have a case-based approach. Okay, what would you like to do next? Once again, examinations, history, and then our investigations. So I like to take a full history. I also like to do a complete neurological examination, including a peripheral exam. And some things that you could add there is, you could say, I'd like to particularly test for fatigability of the proximal and distal muscles. So for example, the way people like to test it is they ask the patient to kind of keep their arms up and kind of repeat that movement, and over time that goes down. So I'd like to, that's for myasthenia specifically. I then like to do bedside tests. So an ice pack test is for myasthenia. The ptosis should improve with myasthenia. So if this is myasthenia, if you put ice pack over your eyelids for a few minutes, the ptosis should basically kind of come back towards normal. That's a kind of feature of myasthenia that comes up in MCQs. Blood tests, specific blood tests for myasthenia are your anti-acetylcholine receptor, which is positive in 85%, and our anti-MuSK, our muscle-specific tyrosine kinase, which is myasthenia as well. And then also associated autoimmune disease. Myasthenia is associated with lots of autoimmune diseases. It's important. If you have a myasthenia patient, absolutely we want to check, do they have any other diseases because they're more at risk. TFTs for thyroid, HbA1c for diabetes, rheumatoid factor, anti-CCP for rheumatoid arthritis. This is why we use a case-based retrospective approach to answer these kind of questions really nicely. How would you investigate? CT chest, because myasthenia is associated with a thymoma. Thymoma is kind of this tumor that affects the thymus gland. Sometimes patients will have a small scar over there where they've had a thymectomy. If your kind of examiner points towards a line around there, you're thinking maybe this is a thymectomy. And then special tests. So tensilin test is not really used clinically, but you can mention it. Always say like, I would avoid this in reality because there's a risk of heart problems, but this is basically where you give edrophonium. It reverses the cause of myasthenia. So they don't have that fatigability. Their strength is improved. You could do an EMG, and this is the kind of gold standard to diagnose. So you do an EMG where you repeatedly stimulate the nerve, and if you keep doing it, the fatigability shows by a decrease in amplitude of the muscle strength. And then spirometry, because myasthenia can cause problems with the respiratory muscles because of fatigability. They sometimes have reduced forced vital capacity. So there we go. Such as a niche diagnosis of myasthenia, you can actually show them a lot of tests in your investigations. Okay, so that's the end of me. That's my two cases. We've done upper limb and cranial nerve exam. I'm going to hand over now to Shuaib, who will take you through to the next two cases of your virtual OSCE.
Hello, everyone. Let me just start sharing my screen.
And I think we'll take any questions overall at the end, probably. So don't worry. Questions.
Can you guys see my PowerPoint at the moment?
Yeah, we can see kind
Yeah.
of interview. There we go. Perfect.
Yeah, got it. Okay. All right. Yeah, thanks, Aaron. Those were two really good cases, two high yield cases that can definitely come up in your OSCEs. And I saw there's quite a lot of questions, so we'll come back to them at the end in the Q&A. But let's move on to this abdominal examination. So you've walked into your abdo station. You know, the first thing you always do is you look around the bed. You don't really see much. You ask the patient to stick their hands out, and there's a fine tremor. Okay, there's a fine tremor, no flap. There's just a slight tremor. Then you move on to the face and you look at the gums and you see that. If you know what the diagnosis is, please don't put it in the chat just yet. So hands, fine tremor, gums look a bit funny, and then you see this scar on the abdomen. So at this point, hopefully you know what's going on, at least with regards to the scar. The other stuff is a bit less clear, but have a think. So take these signs in, process it, have a think about the diagnosis. And in the meantime, I'm going to try and launch a question. Whoops. Sorry. Okay, hopefully that question is launched on the Zoom poll. Sorry, I know some of you have logged in via the Bite Medicine website. I don't know if all of you can access the Zoom poll on the Bite Medicine website. If you can't access the poll, then have a think about the answer. So which of the following is not a cause of gum hypertrophy? Cyclosporin, phenytoin, scurvy, AML, or chronic liver disease? I'll give you about 10 more seconds to answer. So it's quite interesting. There's a nice even split at the moment. Okay, let's leave it there. So there's pretty much an even split across all 5 answers. The majority, 26%, have gone for phenytoin. The answer is chronic liver disease. So cyclosporin, phenytoin, scurvy, and AML, they all cause gum hypertrophy. Liver disease doesn't typically cause gum problems, okay? This is also known as gingival hyperplasia. So what exactly is going on here? What's the scar? What's wrong with the gums? And why does the patient have a fine tremor? Does anyone have any idea? Let's get back to the case. So some people are saying transplantation, liver transplant, fine. But why does he have a fine tremor and the gum problem? Yeah, it's a side effect of immunosuppression. Good. So these two problems here, the gums and the hands, are a side effect of immunosuppressants. And that's something really important to pick up on your exams. You know, pretty much everyone will know this scar is a liver transplant scar. It's called a Mercedes-Benz scar. Less people will know exactly what these two signs are, and that's where you can pick up a lot of points and really distinguish yourself. So, as always, presenting your findings, I performed an abdominal examination on this gentleman who has evidence of a liver transplant. My main positive findings were presence of a Mercedes-Benz abdominal scar, and I also noted evidence of gum hypertrophy and a fine tremor. My relevant negative findings are there's no evidence of decompensated liver disease, such as jaundice, asterixis, variceal bleeding, or ascites, and there is no evidence of infective symptoms. So for pretty much every abdominal examination, you can always say there's no evidence of decompensated liver disease, or you can say there's no evidence of acute liver disease, and there's no evidence of infective symptoms, because otherwise the patients will be too unwell for your OSCEs. So you can just learn this and pretty much stick it at the end of most of your abdominal examinations. So I can see some of you say avoid naming the scar, which is true. I mean, you shouldn't avoid naming the scar. You should describe it first and then give it the name. But it's pretty hard to describe this scar any other way. So I think it's acceptable here to call it a Mercedes-Benz scar. In summary, this is a middle-aged lady presenting with evidence of a liver transplant. The underlying cause is unclear, but possible causes of liver transplantation include any cause of cirrhosis, any acute hepatic failure. And given that this is a middle-aged female, so I don't think I told you guys that earlier, but given this is a middle-aged female, we need to think about autoimmune causes, such as primary biliary cirrhosis. So again, you need to go beyond just saying liver transplantation. If you stop there, that's actually fine, but if you really want to get the extra points, you need to speculate on a cause. So in this case, just list the most common causes because there's no evidence as to what the underlying cause was. And you can just list a few of the common causes and then say, well, actually, this is a middle-aged female, so I'd also like to consider autoimmune causes. You should also say there's no evidence of decompensation, okay? There's no evidence of decompensation. That's really important because that means that the transplant is functioning well. If this lady came in with a Mercedes-Benz scar and she had jaundice and she had a liver flap, also known as asterixis, she had ascites, that means you know that the transplant has failed because she's got overt liver disease. If she doesn't have any of those features, then you can say, well, actually, the liver must be doing its job. The transplant is working. So this is a functioning transplant. And you can say there were features of immunotoxicity. In any transplant OSCE, this is the high yield point. It doesn't matter whether it's the liver, it doesn't matter whether it's the kidney or something else. You always say what the transplant is. So the site of the transplant, in this case, is the liver. You comment on the underlying cause if you can. You mention whether the transplant is working or not working. And you should mention if there's any evidence of immunotoxicity. So those are the 4 things you must mention in your presentation. So here we've said it's a liver transplant. These are the possible causes. It's functioning correctly. And there were features of immunotoxicity. So we've got all 4 of those points in and you've got every mark that you can get. That's what this slide really goes into. So key points to remember for any transplant OSCE. So whether that's liver, whether that's kidney, what the transplant is, obviously, is the first thing. As we said, the underlying cause is the transplant functioning and evidence of immunotoxicity. So, I mean, this is all fairly straightforward. Evidence of immunotoxicity. What causes a tremor? What immunosuppressant causes a tremor? Yeah, tacrolimus. Tacrolimus classically causes a tremor. And what immunosuppressant causes gum hypertrophy? We won't mention it in the question. Yeah, good. Cyclosporin causes gum hypertrophy. Tacrolimus causes a tremor. Tacrolimus can rarely also cause gum hypertrophy. The point is, if a patient is on immunosuppressants, look at the hands for a tremor, look at the gums for hypertrophy. If any of those two things are present, in your presentation, you can say, I noticed there was evidence of immunotoxicity. And then when you go on to talk about your investigations, you can say, I would like to check levels of cyclosporin or levels of tacrolimus. And is the transplant functioning? That can often be hard to tell, but the easy way to do it is for the liver, as I said, look for features of decompensated liver disease. If none of these are present, your transplant is doing pretty well. For the kidneys, look for evidence of fluid overload. Ask the examiner for the patient's urine output. Obviously, if they are fluid overloaded, they've got edema, then that suggests the kidneys aren't working properly. If their urine output is low, that suggests the kidney transplant isn't working properly. If they've got evidence of a other form of renal replacement therapy, then that suggests that their transplant, again, is not working properly. Good. And be aware of your scars. So here I just wanted to highlight Mercedes-Benz is your liver transplant, and Rutherford Morrison, also known as a J-shaped scar or a reverse hockey stick scar, is the renal transplant scar. So these are your two key high yield scars that will almost certainly come up in your OSCEs at some point. And all the other scars are to do with sort of laparotomies, bowel surgery, vascular surgery. So you should be aware of those as well. But really make sure you know the Mercedes-Benz and the Rutherford Morrison. So what would you like to do next? Always start off with a full history, okay? You're going to get so much information. You can literally just ask the patient, what was the cause of your liver transplant? So full history is the most important thing. Bedside observations, you always want a full set of observations, and then blood tests. Liver function and clotting. So these will give you an idea as to how well the transplant is functioning. As I said, you can check immunosuppressant levels to see if they are in the therapeutic range or if they are too high. And then you can screen for possible causes of the liver transplant. So why the patient had underlying liver disease, things like hepatitis, serology, autoantibodies, metabolic causes. You can literally just list a few common things here. And as always, bedside, bloods, imaging, special tests. So imaging to actually visualize the liver transplant itself, you can do a liver ultrasound or a CT abdomen. And if you're concerned about graft rejection, you can do a biopsy. Okay, so if you think the liver transplant is failing, then you would want to biopsy the liver to have a look and see if there's any inflammatory immune response against the parenchyma and the vasculature, essentially. Good. So again, what are the complications associated with a transplantation? Really common question and is applicable for any transplant that you get. So this is a summary for either liver or renal. It's all the same complications, okay? Rejection, recurrence, and immunosuppressant. So think of those three things. Those are your high yield titles. Rejection is split up into hyperacute, acute, and chronic. Recurrence of the original disease process. So, you know, if this is an autoimmune process, if you transplant the liver in, there's a chance that it could be affected by the same autoimmune process. So you need to be aware of that. And immunosuppressant related complications. Of course, if you're suppressing the immune system, they're at risk of infection. Interestingly, malignancy risk is increased, particularly with dermatological malignancies. So squamous cell carcinoma, that's SCC, there's a 100-fold risk, and basal cell carcinoma, there's a 10-fold risk. So you would often see transplant patients on immunosuppressants wearing things like caps, really wrapping themselves up to make sure they don't get exposed to sun, because they are at an increased risk of skin cancer. And as we said, side effects, gum hypertrophy, tremor, and particularly cyclosporin is nephrotoxic, can damage the kidneys and cause kidney failure. So these common complications are applicable to pretty much any transplantation. So if you walk into any transplant OSCE station, you can just reel these off. So it's a nice little table to learn. Okay, before we move on to the next case, do you have any questions I can quickly take? If not, we'll just move on. I'm just looking through the chat. Okay, we'll hold on till the end for the questions, because I'm aware that we're running a bit short on time. So thyroid examination, this will definitely come up in your OSCEs at some point. Really common. I had this in my finals at Cambridge. So have a look at the signs. You walk into the station. I mean, pretty much as soon as you walk in, you should know what this diagnosis is. It's a lady. Her eyes look like they're kind of popping out. Her hands look red. And here we have a piece of paper placed on top of the hands. So in an endocrine station, so a thyroid station, the way to check for a tremor is you always place a piece of paper on top of the patient's hands and you see if the piece of paper shakes. That's just the way endocrinologists look for a tremor, and that's what they'd be expecting you to do, sorry. So you put a piece of paper on top of the hands and you see there's a fine tremor, heart rate's 100 beats per minute and regular, and there is a mass in the neck. So what's the diagnosis here? You just put it in the chat. So what's a specific diagnosis? Yeah, Graves, good. So this is a lady with evidence of hyperthyroidism. She's got a tremor, she's tachycardic, she's got, this is known as exophthalmos or proptosis. They are exactly the same thing, exophthalmos, proptosis, and she's got a diffuse goiter. So she's got evidence of hyperthyroidism. She's a middle-aged lady. She's got eye signs. So this is Graves' disease. Yeah. Which of the following is not a cause of palmarothema? Just let me put it in the Zoom polls. Please don't answer in the chat. So which of the following is not a cause of palmarothema? We've got chronic liver disease, hyperthyroidism, rheumatoid arthritis, pregnancy, and chronic renal failure. So we'll be, I know it's almost 6, we'll be done in the next sort of 10 minutes or so. Give you guys about 5 more seconds on that. Okay, so the vast majority of you went for rheumatoid arthritis, 51% of you. 3% of you went for hyperthyroidism. So this patient had palmarothema. So hyperthyroidism is not the correct answer. Rheumatoid arthritis is also not the correct answer. Just to let you know, this is palmarothema here. So these red palms, that's known as palmarothema. And the correct answer is chronic renal failure. Rheumatoid arthritis, which is what most of you went for, does cause palmarothema. I tried to look up the mechanism and I couldn't really find anything conclusive, but rheumatoid arthritis is definitely linked with palmarothema. Chronic liver disease, of course, increased estrogen leads to increased vascularity, and that causes red hands, or the erythematous look. Same thing with hyperthyroidism, you get increased cutaneous blood flow. In pregnancy, you get increased estrogen, and again, that leads to increased blood flow in the hands. Chronic renal failure is not associated with palmarothema. So again, present the findings in a systematic way. So I performed a thyroid status exam on this 40-year-old lady who had evidence of hypothyroidism. There was a fine tremor and palmar erythema peripherally. She was tachycardic at 100 beats per minute and regular. So regular is very important. There was evidence of exophthalmos and lid lag. Sorry, I didn't actually mention the lid lag earlier. There was a central uniform neck mass, which moved up with swallowing, which is suggestive of a goiter. A goiter is a neck mass arising from the thyroid. Okay, that's just the medical term for a thyroid mass, basically. My relevant negative findings are no evidence of retrosternal expansion and no evidence of atrial fibrillation. So pretty much every thyroid patient that you see in an OSCE will have no evidence of retrosternal expansion. That means the thyroid extending downwards behind the sternum, because that's a massive thyroid mass, and it's unlikely that you'd get that in your OSCE. So you can just memorize this line that there's no evidence of retrosternal expansion. And this patient had a regular pulse, so you can say there's no evidence of atrial fibrillation. In summary, this is a middle-aged lady with hypothyroidism, and given her demographic and the presence of eye signs, in particular exophthalmos, the most likely cause is Graves' disease. Other causes of hypothyroidism include a toxic multinodular goiter and a toxic adenoma. So again, as you literally walk into the station, you should already know what the diagnosis is just by looking at the patient, particularly looking at their eyes and looking at their neck. How do you differentiate between Graves' disease and other causes of hypothyroidism? What are the signs you look for to differentiate between Graves and other causes of hypothyroidism? So eye signs is one. There's two other things. So what are the two other things? Pretibial myxedema and thyroid acropathy. Good. So I'll show you what those signs are in a bit, but those are the three ways you differentiate Graves between everything else. Okay. Quick question on this. Which of the following autoantibodies is most likely to be raised in Graves' disease? So I'll give you about 20 seconds to answer this. Anti-TPO is antithyroid peroxidase, antithyroid globulin, antithyroid releasing hormone, anti-nuclear antibodies, or none of the above. So we've asked this question before we've done a hypothyroidism lecture a while ago, and we asked this question. So hopefully you should know the answer if you went to that lecture. So yeah, good. The answer is antithyroid peroxidase. So in Graves' disease, 70% of patients will have a raised antithyroid peroxidase, and almost all patients, about 95% of patients, will have a raised antithyroid stimulating hormone level. Antithyroid peroxidase is also raised in Hashimoto's thyroiditis. Most patients in Hashimoto's have a raised anti-TPO. About 3/4 of patients in Graves' disease also have a raised anti-TPO. Okay, obviously the classic antibody is antithyroid stimulating hormone, which I haven't put here. So differentials for hypothyroidism, just very quickly: Graves' disease, toxic multinodular goiter, toxic adenoma, thyroiditis, and drugs. So Graves' disease is autoimmune. You have an antibody which stimulates the TSH receptor. Toxic multinodular goiter is probably the next most common cause. And then you have a few rarer causes like toxic adenoma and drugs. Thyroiditis typically causes hypothyroidism, but in the initial stages, you have transient hyperthyroidism. So in Hashimoto's thyroiditis, you can initially have a hyperthyroid state, and that's known as hashitoxicosis. But really, for your OSCEs, I mean, this isn't MCQs, remember, so I don't want to go too much into the theory, but for the OSCEs, you just need to memorize a list. So just memorize 3: Graves' disease, toxic multinodular goiter, and toxic adenoma. And that's enough to get all the marks that you need for this question. So what would you like to do next? A full history and Pemberton's test. I got asked to perform Pemberton's test in my final examinations, and that's where you ask the patient to lift the arms above their head and you check to see if their face goes red. Okay. If the patient has a massive thyroid mass, you get compression of the superior vena cava, and when they raise their hands above their head, they get obstruction of the superior vena cava, and that causes their face to go red. So that's known as Pemberton's sign, and it's looking for superior vena cava obstruction secondary to a thyroid mass. Observations, heart rate and blood pressure. So these patients can be tachycardic and hypertensive. You want to do an ECG to look for atrial fibrillation. And hyperthyroidism also causes hyperglycemia, so you can check the glucose levels. Ultimately, you want to do thyroid function tests and thyroid autoantibodies to confirm the diagnosis. And I'm sure we all know the feedback loop where you have hypothalamus releasing TRH, pituitary releasing TSH, and the thyroid gland predominantly releases T4 and a bit of T3. Most of that T4 is converted peripherally to T3. Okay, that's why we mainly look for T4 in blood tests, because the thyroid gland predominantly releases T4, also known as thyroxine. If your bloods are not conclusive, you can ultrasound the thyroid and you can do a technetium scan, also known as a radionucleotide uptake scan. And in Graves' disease, you'll have a diffuse pattern of uptake. So A is normal and B is Graves. So you can see there's a lot more uptake in Graves' disease because the thyroid is consuming a lot more iodine. We went over this briefly. What signs distinguish Graves from other causes of hyperthyroidism? So eye signs, this is known as thyroid acropatchy. So you get clubbing and soft tissue swelling of the fingers, and pre-tibial myxedema, you get this soft tissue swelling of the shins. Those are the three signs which help you distinguish Graves from the other causes of hyperthyroidism. You don't get these in other causes of overactive thyroid. And these are just the different eye signs you get. It's a mnemonic, no specs. So I'll let you go through that in your own time because I'm aware that we're running over. So no specs. And this starts off from least severe to most severe. So no signs is obviously the least severe form of Graves' eye disease, and sight loss is the most severe. How would you manage this patient? So there are three methods of management. You can give them anti-thyroid medications such as carbimazole or propyl thiouracil. You can give them radioiodine, where the radioactive iodine embeds itself into the thyroid and kills off the thyroid, or you can remove the thyroid with surgery, okay? And it depends on the patient choice. What typically happens is you give them medications. If the medications work, that's great. If they don't, then you usually progress to radioiodine, and you can also progress to surgery. And there's two different regimes, titration or block and replace. We did a quite extensive lecture on hyperthyroidism, so you can go check that out there, or I can answer it in the Q&A if you're interested. Fine, let's finish off on a top decile question. So, which of the following nucleotide sequences is associated with myotonic dystrophy? CAG, CGG, CTTG, CCTG, or none of the above? Oh God, that's quite confusing, actually. Yeah, I'm reading through some of your questions. Radioiodine is a contraindication in Graves' eye disease because it makes it worse. Radiotherapy, on the other hand, is a treatment for Graves' eye disease. I'll give you like 5 more seconds to answer that. Okay, so the majority of you went for CAG. So CAG is which disease? CAG is Huntington's disease. Obviously, I mean, you will never get asked something this difficult on your exam. This is meant to be top decile for a reason, but it's CCTG. Okay, myotonic dystrophy is linked with either a CTG expansion or a CCTG expansion. So this is known as a trinucleotide repeat, and CCTG is a tetranucleotide repeat. And yeah, that's just for your interest, really. But you should actually know CAG is Huntington's disease. That's something you do need to know for your exam. You should also know CGG is Fragile X. So you could have kind of narrowed it down, I guess. Good. So this is what we've covered in the OSCE week. We've gone over cardiology, and we've done murmurs, heart failure, valve replacement, CABG. We've done the common respiratory conditions. We've done common neurological conditions. We have done abdominal conditions and hypothyroidism and Cushing syndrome. So we've covered quite a lot. And if you know all of these cases inside out, you'll do well in your OSCEs, okay? Because this is the common stuff. And if you haven't been to our previous webinars on OSCEs, then we recorded them, and we will be putting them all on YouTube, as well as our Bite Medicine website. So please do check that out. You may know that we have a question bank on our website, and that takes you through all of these main conditions, going through first steps to pathology, and the same with the textbook, again, taking you from cases to complications. So please do check that out. We will take your questions if you just post them in the chat, and please do fill out the feedback forms which are coming your way. And please do check Aaron out. I think he'll go into a bit on what he does on YouTube and Instagram, but he does some great OSCE stuff on his social media. So please do check him out. You are all very welcome. Aaron, I'm going to unmute you, okay?
Yeah, sorry. Yeah, thanks guys. Hope you found that useful. So that was the end of the OSCE week, and yeah, we're around to answer any questions. Hope you guys found it useful, and just best of luck with your exams. Fill in the feedback form, please. And yeah, Shoaib mentioned, please check out my YouTube. My socials are there, and yeah, good luck with all your exams, guys.
I'll try and share the link in the chat if you just give me a second. But in the meantime, just post your questions, and we will get to them. Oh, you're all very welcome. Thank you for your kind words. If you have a look at our Facebook page and Instagram, we'll be releasing a new schedule probably tomorrow.
Brilliant. Azim's put the feedback in. Okay, Shoaib, do you want to?
Yes, I mean, there's quite a lot of questions coming through. Let's just have a look.
Can you see the chat, yeah?
Yeah. You might know this one, actually. It's an opt-down question. So why do people get red color desaturation in multiple sclerosis?
So multiple sclerosis, causes lots of things, as we talked about yesterday. It's basically this causes multiple lesions in time and space of the central nervous system. One of the most common sites is the optic nerve, and the optic nerve is responsible for your visual acuity, your color vision. That's why you get red desaturation. Red is the first color to go just because of the way the cones are kind of orientated. They've got high sensitivity to red, and then it causes impaired eye movements and various other features. So that's why red is particularly sensitive. Do you guys have videos on examinations like Geeky Medics? Maybe coming soon?
Coming soon, watch this space, yeah. So there's people asking about the thyroid and the Pemberton's test and all of that. So I was always told to never actually perform this in an OSCE, but in my final year OSCE examination, I turned to the examiner at the end of the exam, as you do. I presented and I said, I would like to perform Pemberton's test. Would you like me to? And he said, yes. So that's why I did it. I wouldn't go ahead and do it straight away. I'd offer it to the examiner. You just get the patient to lift both of their arms above their head. And if the thyroid is big and is extending retrosternally, so down towards the chest, it will, when you raise the arms above the head, you narrow the thoracic inlet, and that can cause compression of the superior vena cava. If you get compression or obstruction of the SVC, that causes your face to become red, and that's known as Pemberton's sign. Okay, obviously when you see that, you then tell the patients to put their hands back down because you don't want to obstruct it for too long. Hi, I'm confused about anti-TPO in Graves and Hashimoto's. So it's positive in both. It's positive in about 95% of Hashimoto's patients and about 70% of Graves' patients. It's just an association that you need to know. But of course, the first line autoantibody in Graves' disease that you would measure is anti-TSH, antithyroid stimulating hormone, which is present in almost all of Graves' patients, about 95% also of Graves' patients. Is this approach of studying from MRCP preparation, because we were not taught like this in med school? What do you think, Aaron?
I think, first of all, this is nothing novel that we're talking about. I think it's just this different style of teaching. We weren't also taught like this in med school. I think it's because there's nothing wrong with teaching like this. I think it's very case-based. It's very exam-orientated, which can have its pros and cons. I think it also makes us better doctors. I never sat the MRCP. I did my FRC Opt kind of exam. So I think this is just something that we kind of realized after kind of working together as med students, that this was helpful in a different form of studying that made it kind of more useful use of our time. When I've spoken to like kind of registrars who prepare for PACEs, I think Shoaib's done his PACEs, then they do, a lot of them do kind of follow this case-based approach just because it's more efficient. And I think the more senior you go, the more interested you are in finding and coming to a diagnosis. Whereas in med school, there's a lot of emphasis on just doing the examination routine. But I think it's nice to start off with that kind of like high level of thinking, which is, what is the point of this? Is to pick up signs and present. Is that right, Shoaib?
Yeah, like, I mean, I've done my PACEs, and what I did in my final year OSCE is pretty much the same in what I did in my PACEs, but obviously in PACEs I had more knowledge. I would go about things in exactly the same way. The book I used to prepare for my final year OSCEs was Cases for PACEs, which is a MRCP book. It's the same principles. You present, you list your positive findings, you list your negative findings, you give a summary, you try and give a cause for the diagnosis. At the end of the day, you're being examined by consultants and registrars who've all done their postgraduate exams usually, so they actually probably prefer to see that. I know you might not have been necessarily taught like that in med school, but med school OSCE teaching is a bit, it can be a bit variable, right? Because it's usually a bedside teaching, and so every student's going to get slightly different teaching on OSCEs. So I would definitely follow this approach personally. But obviously, if your medical school are giving you specific guidance to do things a bit differently, then follow what they say. But yeah, what was I going to say? Why does ice relieve ptosis in myasthenia gravis? Because ice prevents the breakdown of acetylcholine. Okay, so you get more acetylcholine in the synapse, and therefore it increases the strength of those eyelid muscles.
Anything that you didn't prepare for which caught you off guard in OSCEs? Oh yeah, absolutely. Like, I think it's really important to say that despite going on and drilling this approach to you guys over the last week or so, we still both had numerous cases in our stations that we couldn't pin down to a diagnosis. And and it's really important to not think, oh God, I did so bad. Like, by using this approach, we were still able to present clearly and answer Viva questions clearly. And most of the time what happened was either the diagnosis was literally like, there was no diagnosis that you could actually come to. It needed like kind of examination. It can need like investigations and stuff. Or I'd get told, I remember I had, for anyone who's a Cambridge student, this always, I'm not sure if I'm allowed to say this, but oh well. There's a respiratory patient that comes up very regularly that has telangiectasia, which is hereditary hemorrhagic telangiectasia, which has kind of a link to respiratory condition. At the end of the station, my examiner said, have a look at the kind of tongue and all that stuff. And then I was like, oh, okay. So I missed that sign completely, but suddenly I was like, okay, so I've still presented it really clearly, all my positive findings and what I think. And now I can answer my Viva questions because they've given me a little clue. So yeah, don't think, oh, because of this, I'm expected to get every single case first time round. That's unrealistic, but this is just hopefully preparing you for those moments where you kind of get completely thrown off to still do a pretty good job.
Yeah, I'd say that's fair. Like, I mean, you can maybe get 80% of what you know really well come up, and then there'll just be 20% where you don't really have a clue. Like I still remember for my respiratory condition, I still don't know what the patient's diagnosis was. But you know, if you present it, you do a slick examination, the examiner will help you along, and you'll be absolutely fine. Do we need to only mention one of the decompensated features of liver or renal disease? You can list a few. You know, that you're not gonna, as long as you don't drag on, you can say there are no features of decompensated liver disease such as jaundice or ascites. You know, you can just list one or two, or you can list all four if you're able to get it out slickly. What else? So someone's asked, hereditary hemorrhagic telangiectasia more presents with bleeding. So yeah, it can present with hemoptysis, so they can get lung bleeding in the lung. That's probably why it came up in the respiratory station. Is exophthalmos reversible?
Oh yeah. Exophthalmos is just another word for proptosis. So it depends on the cause of the exophthalmos. So thyroid eye disease, yeah. So if you get thyroid it's very variable. Sometimes I think it's very difficult for these patients to get it under control. You're using kind of anti-thyroid medications, but yeah, it can change, because basically the exophthalmos is due to these patients have got big mass, as Shoaib mentioned, in the thyroid that's pumping out all these extra kind of anti-TSH, and these basically, the anti-TSH normally binds to TSH receptors in the thyroid. So they also have similar binding sites to kind of the extraocular muscles and the fat tissue in the eyelid. That's what causes kind of the exophthalmos. So if you control the source, then yeah, it does reverse. Sorry for a basic question, but how long do you spend measuring the pulse so you don't end up wasting time? That's actually
a really good question, actually.
Yeah, that is good. I usually did it for 15 seconds. If it was regular, I just said, and I just kind of estimated it. I wasn't always like, really hard to, spend too long.
The examiner will not know what the patient's heart rate is. It's impossible, obviously. So my advice is use the pulse to calm yourself down. So when I would check the pulse, I would use that 10 seconds, if that 10, 15 seconds, to look at the patient and try and figure out what the diagnosis is, because that just gives you more inspection time. Calm yourself down, figure out what the diagnosis is, and just estimate the pulse. The examiner's not going to know if it's 60 or 70. Obviously, you need to figure out if it's regular or irregular, but that just takes, you know, a few seconds. Otherwise, just use those extra few seconds to calm yourself down and figure out what the diagnosis is and what your next steps in the examination are. I would not spend any more than 15 seconds on the pulse, because you'll waste too much time.
This is a good question. We'll do a few more, then we'll probably wrap up. Please, could you give us an idea of what the vignettes might be for these cases? For example, you were the F1 in A&E and the patient has come in with, for example, when I see a patient in an OSCE, I really struggle to say what I do next, because in reality, the patient looks well. Okay, so good question. Your patient is well, but an OSCE is also kind of an artificial scenario. So you need to put yourself, so normally it would say something like outside the station, you're the final year medical student, or you're the junior doctor on the ward, you've been asked to perform a respiratory examination on this patient. They're kind of pre-prepared laminated sheets that they just stick on there. You won't really be told the name or the date of birth or the age, because patients change, they rotate. Patients don't spend 3 hours in one room because it's not nice to a patient. So you need to assume that you are a doctor, you're a medical student, whatever they say, in kind of an A&E scenario. So just because the patient is well and stable, you'd still do all those investigations and tests as if it's the first time you're seeing this patient who's presenting with a problem. Don't think, oh, this patient's so well, so I don't really need to check their heart rate or blood pressure because they look so well. I wouldn't do an ECG, I wouldn't do a chest x-ray because they're stable. Is that right?
Yeah, precisely, exactly. How do you measure pulse and respirate at the same time? So it's the same principle. What I used to do is I didn't actually used to measure the respirate. I would just look at the patient, and if they're breathing normally, I would say the respirate is 16 breaths per minute, because that's a normal respiratory rate. You're going to waste time, honestly, counting the respirate. So I wouldn't actually count it. If they're breathing normally, just say 16. If they're breathing fast, then count it. Or if they look like they're breathing really slowly, then count it. But you're not going to have someone really who's breathing slowly in your OSCE. You'd either have someone who's got a normal respirate or a fast respirate. So if they're breathing normal, just estimate. If they're breathing a bit fast, then you can try and count it if you want. But again, the examiner's not going to be counting it at the same time. So as long as you say something reasonable, that's absolutely fine.
Yeah, 15 seconds for each is fine, yeah.
Yeah. I'd say even that's probably a bit too much. I would
Yeah.
say just 10 seconds for each one.
Just
So should we introduce ourselves as our actual position or the position the station has given us? So
no,
you, if
yourself, I think. Yeah, right.
sorry.
You should be yourself, right? You shouldn't say you're a junior doctor if you're a medical student, right?
I mean, it might, from what I remember, they didn't even tell us in the scenario. It would just be like, this patient has shortness of breath. Please examine their respiratory system. In which case, I would just say, I'm Shoaib. I'm a final year medical student. Yeah, usually just introduce yourself as yourself. That's fine.
Cool.
Is that about everything?
Yeah, I think there's a few more, but yeah.
Okay, should we leave it there? If you have any more questions, you can either try and contact us or you can post them on our Facebook group and we will try our best to get to them.